So my name is Jeff Bernson. I work for an organization called PATH. It's a nonprofit organization. We work in global health. I am the Director of Results, Measurement, Management, and Learning at PATH. And I get to wake up every day and work with PATH's 250 projects around the world to help them measure the impact that we're having in terms of the lives that we're saving or morbidity that we're avoiding through a lot of our public health interventions. And I'm lucky enough to work on a project that Exasol is involved in with us. It's an exciting partnership between the social sector, which is what PATH represents, the public sector, and also the commercial sector, which probably involves many of you as well. But first, just a little bit on malaria. I don't know, just a show of hands, how many people have had malaria in the room? I have. This is really a good thing that one of us has had malaria. And oftentimes, this is the image that people think of when they think of malaria. They think of the mosquito, often described as the most dangerous animal on Earth. But actually, malaria is not caused by mosquitoes. It's caused by a parasite that lives primarily in the human blood. So we're actually the reservoir for this disease. Mosquitoes merely are the transmitter, so they'll bite an infected host and then they'll go off and bite someone who's uninfected, and that's how the disease is spread from one host to many. And this is kind of precisely the challenge that we have, because this is not a small challenge. Malaria is still one of the top 5 killers of children under 5 today. There's over 400 or 200 million cases per year and 400,000 deaths per year due to malaria. And it actually disproportionately affects pregnant women and children. So this is a challenge that's been with us for thousands of years, and one that the public health community has not yet really gotten their arms around until very, very recently. In the last decade, things have really dramatically changed. And it's also a problem that the organization that I work for, PATH, really loves to take on, these sort of wicked global health challenges. We work across 5 different platforms, trying to really search out breakthrough health innovations that we can apply in low-resource settings. And that's precisely the story that I'm going to tell you a little bit about today in terms of how we have leveraged both technology and some of the on-the-ground know-how that our organizations together can bring. So a little bit about the disease. Why is it so difficult to figure out how to get this parasite that causes malaria? You have to consider sort of the percentages in this particular complex problem. 1% of this parasite is actually found in mosquitoes. So just think about that. The majority of our efforts today to eliminate or even control malaria have been focused on trying to keep mosquitoes from biting people. But the percentage of the parasite that lives in mosquitoes is quite small. 99% of it actually lives in humans. And we're, as I said, the main reservoir for this disease. Whereas 20% of that parasite is actually visible to us. If someone contracts the disease, they might show signs or symptoms of it. We'll see 20% of that parasite. But 80% of this parasite is actually unseen. It's asymptomatic, so people who don't have any symptoms, they've built up an immunity to the disease and they're walking around. They can live, they can work, they can do many things. They might feel a little bit ill, but it doesn't really affect them too much and doesn't affect them enough to go see any sort of clinician or health specialist. And that's the reservoir that continues the transfer of this disease from human to human through mosquitoes. So therein lies the challenge of trying to find this hidden parasite in this population of seemingly healthy people. So that brings us to Zambia, and this is the country that we're working in partnership, actually with some of you in this room, Exasol included, the Tableau Foundation. Zambia is a country which we consider highly endemic. It's made up of about 14 million people, all of which really live at risk on getting this disease. And yet, at the same time, it's a country that has made tremendous strides in the last decade in terms of driving down the prevalence of malaria. So much so that in the last year, actually, they have established a really bold goal, which is to eliminate malaria within their borders. And this is very, very ambitious. I don't know if you know where Zambia is, but it's completely surrounded by other countries. And so it's something like 6 or 7 countries that are also all malarious, save one, I think. And yet they have established a pretty ambitious vision to go out and accelerate the elimination of this disease. And it's one that we're happy to be a part of, and also one where we're leveraging a lot of these partnerships with global tech companies. So why have they been so successful? Just to give you some understanding, they have been really successful in promoting some known interventions which help us tackle the disease. You're looking at insecticide-treated bed nets. When families sleep under bed nets, they're less likely to be bitten. When we deploy indoor residual spraying in houses and cover surfaces and walls, we also eliminate the ability for mosquitoes to bite indoors. And they've also deployed rapid diagnostic tests and better drugs so that when someone feels sick, they can go to a health facility and they can be diagnosed. And if they're positive for the disease, they can be treated. So this is tremendous advances, and Zambia itself has made incredible strides in making sure that these key interventions are available. And so that's why they're pretty confident at this stage that they're close to an elimination strategy and one that they can implement by 2021. That said, there's still some challenges ahead. You're looking at a map of Zambia, and mainly right now, you can only go to sort of one of 2,000 places to get malaria, diagnosed for malaria and treated for malaria, and that's these geocoded points on the map. These are all of the health facilities and clinics in the country. But when you start to think about what it takes to eliminate this disease, we have to go after that hidden parasite in populations which are seemingly healthy people who don't really have a whole lot of reason to go to a health clinic if they're feeling okay. So together, PATH, in partnership with the Zambian Ministry of Health, took a look at this problem and thought about, well, how can we increase access to some of these points, these facility points where people get access to better diagnostics and drugs. And what we came up with was we started to mobilize community health workers. These are volunteers that live and work in communities. And basically what we did was we armed them with the same diagnostics and drugs that you would find at a facility. But instead, the community health workers would just go out or be in the communities where they live and work and be available to catch cases, essentially, where with a simple finger prick and a rapid diagnostic, they can test for these cases. If they're positive, they'll see it very quickly within 20 minutes in a rapid diagnostic test. They'll record that information in a logbook, and then they'll provide the drugs. And very easily and quickly be able to start knocking out this disease one person, one family at a time. What's great about this is it eliminates all of that walking that people do to get to a health facility. It also eliminates lines, and it eliminates, more importantly, the time that it takes to get drugs, diagnostics and drugs. And just to kind of give you a sense of scale, what that looks like, the area that we have focused on in the Visualized No Malaria initiative is southern Zambia, mostly southern province. This is a grouping of about 15 different districts in the south of Zambia. And what happens is we added to about 264 facilities, we added about 1,500 access points. Which greatly improved the reach, essentially, and also the use of drugs and diagnostics over time. So much so that I'm happy to report that we've done this since 2014, and what we see is a nice decrease over time of the number of cases. You're looking at an area chart, which is the number of malaria cases that have occurred since 2014. What's interesting is, of course, the trend line is going down. You see these spikes along the way. Those spikes are what we call the transmission season. And so that's when it's most wet, and also when you see that most of the mosquitoes doing most of their biting and transmitting of the malaria parasite. But over time, what we've seen is a 90% decrease over this period, which is great. And we're also starting to get below 10,000 cases this past year as where we peaked out. And that's an incredible amount of progress. As you know, as you get lower, it's much harder to start statistically, to start really decreasing the amount of cases that you're going to see. So we know that this effort is having an impact. The other key thing to notice is in the area chart, the orange represents the number of cases that are being seen through facilities. The red and the yellow put together are the number of cases being seen through community health workers. And over time, what you see is now more than half of the cases are being seen in the communities, which is a very exciting change. It's also doing things, not only reducing wait time for people to get treated and making sure they get treated earlier, but now facilities are freed up to do more things like treat other diseases and shift their time essentially to focus on other health issues, because as you might imagine, malaria is not the only problem in southern province in Zambia. So this is great. Another kind of sense for scale, we're going to just take a look at southern province, which is the upper chart, compared to western province, its neighbor. Traditionally, these two provinces have actually had the same malaria profile. In 2010, in fact, southern province had a much higher prevalence rate than western province. And you can see in western province, where we haven't rolled this particular set of interventions out, we're peaking out around 100,000 cases. That's a lot of malaria in any place, actually. Whereas in southern province, what's happened is it's slowly going down over time. And I think for me, what is most exciting is you see towards the edge of the right-hand edge of this chart, the community health workers are now being deployed in western province. So that in western province, you see at the bottom chart, they're now starting to detect about 15% of the cases, which is really exciting because they're starting to take on some of these innovative ways of detecting and treating cases. So the impact is incredible, and certainly we are going to need a stronger push to make sure by 2021 we get far below 10,000 cases, we get to 0 cases of malaria, but I think we're well on our way. And just need to start optimizing this intervention throughout the rest of Zambia. But one of the ways that we have to do that is by putting this kind of data in the hands of the decision makers. So traditionally, the decision makers in Zambia are the people who work at the district level. It's what they call the district health management teams. It's made up of a district medical officer, it's made up of a district information officer, it's also made up of a malaria focal point. But oddly, this is the same team that doesn't have access to the data that they help collect until now. So by leveraging a lot of the tools that you have probably taken a look at today, Exasol is included in them, but also leveraging Tableau and Alteryx, we're starting to make this data available. And especially with some of the technology that Exasol is providing us, we're going to be able to make it available faster and especially faster in low bandwidth settings. And this is a group, as you can see, who spends a lot of their time with the data in terms of pen and paper and not in a very dynamic fashion. But now we're able to start to develop dashboards that they themselves can construct, which are going to help drive a lot of the decision making. So I'm going to go through 3 use cases of some of the dashboards that we've helped develop. And the idea here is to hopefully entice many of you and other ideas that you could potentially come up with to help us through this fight to eliminate this disease. So the first use case that we developed probably seems a little bit evident. It's around the data quality. So as many of you know, when you have terrible data quality and you don't believe your data, it's really hard to make good decisions with that data. That's really no different in public health. In fact, people's lives are on the line if you don't believe the data and you're kind of going with your gut. So one of the things that we did was developed a data quality dashboard that was led by our district health teams in terms of this was their first use case. Because what they wanted to do is they wanted to look at their specific district and say a list of 20 or so facilities, and they wanted to be able to rank them and see how they were performing and be able to, for those facilities to actually compare themselves to each other and have that online. Not too dissimilar to the last case studies that we heard about in the restaurant industry. But in this case, they wanted all of that to be transparent, and they wanted to be able to quickly understand, were facilities reporting, were they reporting on time, were their reports complete, and were their reports error-free? Because that was going to be the basis for the epidemiological data that they were going to be able to take next and make resourcing decisions. So we made this available. We put it online for them to look at, for everyone to look at, and the effects were amazing, so much so that the next step was, okay, how do we now start to push this information out and close this loop? Where right now we're trying to attract people to the website to see whether or not they have good or bad data quality. Let's go ahead and push that message out. So we partnered with a group called Twilio, which is a cloud-based messaging company, and they helped us start to blast out these quality reports. And we did that through PDFs and through email, but we also started to send SMS messages. And these SMS messages started to go directly to the facilities that were not reporting. So the first thing was just to get people to report and report consistently. And lo and behold, once these messages started going out, we saw a 30% drop just within the first 4 weeks of missing reports. And just by opening up the transparency for this. So that was an incredible piece of progress based on very, very little technical input. For us, it was just the tip of the iceberg in terms of what we could start to do with this data. The second, and of course, we got tremendous feedback from some of our users who, for the first time, were not calling up their health facilities and saying, hey, could you send in that report? These reminders were going out in an automatic fashion. This is kind of unheard of in a low resource setting where you don't have a lot of bandwidth, you can use text messaging, but it costs money, and all of this was being leveraged through our partnerships. The next use case was, okay, now that we started to improve quality of the data, how could we then start to use this epidemiological data, the data on cases that we were collecting, to help us understand where to put resources? So resources could be, where do we spray more? Where do we put more bed nets? Where do we make sure that we have commodities? And what we decided to do with our user groups was develop a dashboard where they could start to see, from one transmission to the next, comparing this transmission season to the last, what changes are we seeing? And so what you see on the right-hand side is a line chart that's looking at incidence of malaria, and then it's comparing this year versus the year before, and then they wanted to be able to take a look at a map of Southern Province and be able to quickly identify hot and cold spots. Hot spot would be an area that changed dramatically, had a spike in incidence. A cold spot would be a place where we saw a dramatic decrease. It doesn't mean that we do nothing in the cold spots, we just do different things. This is an incredible shift in terms of how the Zambian government started to look at data. Before, we would apply resources and spread them like peanut butter, right? A very thin layer across the whole geography. But now we could start to target this data in a very, very direct way. And this, of course, was really exciting for folks. And the first use case we saw play out was at a national planning meeting that took place last year. But now what's happening is, now that the resources are in place, district health teams are now able to take some of that data and focus it even at a more granular level, at the community health worker level, which is below the health facility level. So the last use case is really one that, this is the direction that we're headed in, because really what we've done is we've really started to mobilize a lot of the routine data that we collect on a day-to-day or week-to-week or month-to-month basis. But then working with some of our experts and some of our partners, we started to get involved in working with some of our data scientists. Some of them are based at some of the companies that are here today. And what they encouraged us to do is to do more with big data. Obviously, for a lot of public health problems, there's a lot of data that can be leveraged out there. Malaria is no different. And actually, temperature and precipitation data are key drivers for where malaria habitats may pop up next. Wetness, as you might imagine, is a key driver for where mosquitoes are going to breed. And the good news is a lot of this data is available. It's free, it's part of the public domain, easy for us to get, but we needed good ways to store it, good ways to manage it, and good ways to make it available to the district health teams that needed to use it. So we started to think about, well, what kinds of models could we build with this data that could tell us, again, where malaria might show up next. And one of the things that we did was developed a topographical model that really helped us understand the flow and pooling of water data. And so this is precipitation data and how it flows over the topography of one district in Zambia. And what you're seeing here is over a transmission season, that's a few months, you're seeing how the water is starting to flow, which is the blue. The orange and the deep orange is where water is pooling. And those areas are most likely good areas for mosquitoes to create breeding habitats. And so then what we started to do is think about this data in terms of another big data set that we that was made available to us. And that was starting to map all of the domiciles in Zambia. And so working together with Digital Globe and Mapbox and Hot OSM, we started to map close to 3 million domiciles in Zambia. And we started to take these data layers and put them together so that we could start to see, look, when we start to look at wetness in relationship to incidence of data and also in relationship to where people live and where we have resources, can we start to model or predict where malaria is going to come up next and where we have or traditionally have not had resources? This has been a game changer. As you might imagine, much of this data has not even been made available to district health teams or even at a national level in Zambia. But what's exciting is, again, with technology like Exasol, what we can start to do is take an amazing, I mean, this is billions and billions of rows of data, and start to make it available, especially in low bandwidth areas. Which for us, we feel like is, regardless of whether our model needs improvement or not, just to have access to that information is going to be a game changer. And so ultimately what we're aiming towards is to develop what we call situational awareness dashboards, where it starts to bring together all of these layers of information together and also come up with recommended actions, so that when we start to see a confluence of variables that drive this disease, that it's no longer going with someone's gut about what to do next, but it's actually a set of recommended actions that can start to drive where do we put scarce resources. And that's something that we're headed towards in terms of some of the partnerships that we have to develop better deep learning and better artificial intelligence and actually embed it in some of the dashboards that we're developing. So with that, I want to say it has been a real pleasure to be able to present this, this project to this group. This is a highly technical group, but it's kind of precisely for that reason that I'm really happy to be here, because whether you're a startup group or whether you're a really mature company, these kinds of initiatives are incredible opportunities. they're not just opportunities to collaborate and to understand maybe new challenges and to really sort of break through perhaps into areas that you haven't considered, but there are also opportunities to give back. So whether you decide to talk to us a little bit more about Visualize No Malaria, I guess my main encouragement is there is a wealth of intelligence and resources in this room. Whether you have 2 weeks a year or whether you have 6 months a year, there's an opportunity to give back. Not only do I think that that's going to be helpful to your bottom line and potentially something that can really help motivate employees that work for you, but I also think it's an opportunity to contribute to something greater. So with that, I thank you, and I'm going to be around for the rest of this afternoon into tomorrow if anybody would like to discuss this further, and that's it.